Arthrocentesis, or joint aspiration, is an important diagnostic and therapeutic procedure for the emergency department. It may help differentiate the etiology of a joint effusion and may provide symptomatic relief or assist therapy by removing offending material from the joint space. Indications for arthrocentesis include any joint for which removal of joint fluid would enable you to diagnose a joint infection, inflammatory arthritis, acute fracture, or to relieve the pain of a large effusion. A similar approach may be used for injection of a local anesthetic or anti-inflammatory medication. Relative contraindications include disruption of the skin or the presence of a skin infection overlying the area where the needle would be placed, as this may increase the risk of introducing infection into the joint space. Presence of a coagulopathy is also a consideration, as it may increase bleeding within the joint. The procedure should be performed with sterile technique. Equipment needed for the procedure includes clean gloves, gauze squares, chlorhexidine solution, sterile drape, local anesthetic, a 25 to 27 gauge needle with a 5 cc syringe for anesthetic injection, an 18 or 20 gauge needle with a large syringe to aspirate fluid, specimen or culture tubes, and ultrasound with sterile probe cover if real-time ultrasound visualization is planned. For illustration purposes, sterile drape and probe cover will be omitted. The joint space of the elbow can be accessed through a lateral or posterior approach. Avoid a medial approach because there is increased risk of damage to neurovascular structures. Both approaches will be described here. For the lateral approach, the elbow should be rested on a stable surface, like a table, with the joint held in 90 degrees flexion. The joint should be thoroughly inspected for signs of infection prior to procedure. Slightly pronate the hand to increase the joint space. Palpate the elbow to identify landmarks, locating the radial head, lateral epicondyle of the humerus, and the lateral aspect of the olecranon. Ultrasound will help to visualize these structures and confirm the presence of an effusion in the joint space. A high-frequency linear array transducer should be used. The target for needle insertion is the center of the triangle created by the radial head, lateral epicondyle of the humerus, and the lateral aspect of the olecranon. Prepare the aspiration site using sterile technique. Inject local anesthetic superficially, avoiding injection into the joint space. If infection is suspected, introduction of anesthetic may cause false negative culture results. Needle insertion and aspiration can be visualized with ultrasound using a perpendicular, out-of-plane approach, with the probe positioned over the radial head and lateral epicondyle. The needle should be directed medially toward the medial edge of the antecubital fossa. Direct the needle toward the effusion and visualize aspiration. Aspirate as much fluid as needed for diagnosis or symptomatic relief. Remove the needle and place a clean dressing. For the posterior approach, the elbow should again be held in 90 degrees flexion on a stable surface. This technique may be facilitated by ultrasound guidance. Place the ultrasound probe in a transverse position at the posterior distal humerus just above the olecranon. Prepare the aspiration site using sterile technique. Inject local anesthetic superficially, avoiding injection into the joint space. If infection is suspected, introduction of anesthetic may cause false negative culture results. Place the ultrasound probe so the target area between the distal humerus and olecranon is visible. Place the needle perpendicular to the ultrasound probe so you will visualize your needle in cross-section, out of plane. Direct the needle toward the effusion and visualize aspiration. Aspirate as much fluid as needed for diagnosis or symptomatic relief. Remove the needle and place a clean dressing.